All right. Hello. Welcome everyone to today's NeuroTalks webinar. Computermatics NeuroTalk webinar series is to share leading research and clinical practices surrounding epilepsy and other primary brain disorders. The purpose of this webinar is to facilitate the knowledge sharing, the community connections, and also inspiring clinical advancement in neurophysiology. So before we dive into today's presentation, I will quickly go over our standard housekeeping items and then required compliance disclaimer. First, let's test the audio. If you can see me in the video and hear me in audio, please enter 1 in the question area. So there is a question area. Yes, okay, great. Thank you. So today's event will featuring a 30-minute presentation by our guest speaker, Dr. Jurriaan M Peters. This will be followed immediately by a 10-minute Q&A sessions. So if you have any questions during the talk, please type them directly in the Q&A box. My colleagues, William, will be monitoring your submissions and he will read your questions during the Q&A session. So first, let me share the screen and do a kind of a regulatory required disclaimer reading. So down here. So the information in the NeuroTalks webinar represents the views and opinions of a presenter and do not necessarily represent those of Computermatics. Computermatics does not make any representation or warranties regarding the accuracy, applicability, fitness, and completeness of the information presented during the talks. The information presented in the webinar is not intended to be substituted for professional medical advice, diagnosis, or treatment. Computermatics does not seek product promotion, sales generation, or any other commercial values through this webinar. So let me share the screen to give the presenter right to Dr. Peters. So all right, so let me give a brief open remark. So it is my absolute honor to introduce our guest speaker, Dr. Jurriaan M Peters. Dr. Peters is the principal epileptologist at the multidisciplinary tuberous sclerosis clinic at the Boston Children's Hospital. He directs the localization laboratory at the BCH. Jurriaan will introduce his clinical and research focus in the beginning of his talk. Dr. Peters is an associate professor of neurology at Harvard Medical School and is a pediatric neurologist with additional expertise in epilepsy, clinical neurophysiology, and neuroimaging. He earned his MD at the Catholic University of Leuven, Belgium, and his PhD at the University of Utrecht, the Netherlands. He completed his child neurology training and the clinical neurophysiology fellowship training at the Boston Children's Hospital. So please join me in giving a warm virtual welcome to Dr. Jurriaan M Peters. Dr. Peters, the floor is yours.
Well, thank you very much for having me. It's an honor for me to talk in this series. I am at home today and we have some people working on their yard. So if the background noise gets really loud, let me know. We can close some more doors. Hopefully it'll be manageable, but just send me a message or let me know otherwise. I will switch to my slides. Wei, can you tell me if they're advancing properly?
Yes,
so,
I can see it.
In my daily life, I'm a clinician and epileptologist, and I treat kids with refractory epilepsy. My research kind of tailors right into that, where I try to discover how it's possible that one focus in the brain gives rise to not only focal seizures, but over time can make the entire brain dysfunctional. And how is it possible that this activity not only recruits neighboring brain, but eventually affects the entire brain? And how can we intervene in this project, in this process, in an informed way? Meaning like target the focus, but also how early is this needed? And I will focus on that. I tailored my talk a little bit to focus also to include earlier work that I was doing in epilepsy or EEG source localization. And the talk has become too long, and not realizing that we want to have this seminar end on time. So I'm going to skip some slides here and there to keep things in line. And so forgive me if I sometimes go a little faster, because I want to deliver some key messages, but also show you some small improvements and innovative little tweaks we've done to source localization. These are my disclosures. I put Compumedics on because I'm working a little bit with them. I've started to work a little bit with them on perhaps doing a teaching course, but nothing official yet. So after this talk, I would like you to recognize that seizures have regional effects and also network effects. And not all generalized seizures are from rapid secondary synchrony, but actually can represent a disorder of networks themselves. And then interventions can be aimed at the focus, but may also be aimed at key nodes of the networks. And we are refining this approach as we speak. I use tuberous sclerosis complex as a model disorder. And by model disorder, I mean a disorder that we can learn lessons from and apply to other early pediatric epilepsies. Hold on one second. And we apply these lessons to focal cortical dysplasia and other lesional epilepsies, but basically the model is one of early onset epilepsy. TSC pathway is not relevant for this talk, but TSC is a lesional model, as the patients have multiple scattered lesions throughout the brain. Here you can see these tubers that are white, fluffy, juxtacortical lesions spread throughout the cortex. And there are other types of lesions in TSC, but for the purpose of this talk, they're not really relevant because they do not generate seizures per se. And we're going to focus on tubers. And TSC is also interesting because it's often diagnosed before the patient is even born. There will be cardiac rhabdomyomas here visible on the screen in the patient's heart. And then if we do prenatal imaging, so of the pregnant mom in the MRI scan, we can actually diagnose tuberous sclerosis formally through imaging or through genetic work. And over time, almost every child with TSC will develop seizures. And here is a large cohort of 160 patients that were followed for several years over 5 centers across the United States. And you can see that in the first months, in particular month 3 to 9, many of them will develop infantile spasms, and more gradually, more linear trajectory is the emergence of focal seizures. And they can occur in any combination and in any order. And we've been trying to predict some of these seizure types so that we can tailor treatments. One particularly devastating seizure types are infantile spasms, here shown in a little baby. And this is a video that is public. I got it from YouTube. But infantile spasms and epilepsy are, they're both, and epilepsy in general, are associated with marked developmental delays. So the ultimate goal of epilepsy surgery and epilepsy treatment in TSC is not just to stem the seizures and to make these kids not have seizures or seizures at dangerous moments, but also to optimize their neurodevelopment. And here in this in the same series that we talked about, 160 children followed over 5 years, several years, we can see that by 24 months, that the Mullen skills of early learning, a measure of cognition in this age group of infants and toddlers, is split up into almost a bimodal distribution. On the left side, those who have epilepsy, and on the right side, who do not. And so there is a model or concept where epilepsy drives neurodevelopment as well. So here is a brain, and the abnormal brain causes seizures. The abnormal brain also causes learning problems. And when the seizures themselves affect the learning as well, form an independent hit or a second assault on the learning process, one speaks of an epileptic encephalopathy. And this is often further compounded by the use of medications that affect the brain, because they're all psychoactive almost by definition. And so if we can prevent seizures and limit these effects on development, then you basically get an optimal neurodevelopment within the context of the poor cards that you were dealt at birth with this particular disorder. And we're trying to optimize development in TSC by addressing these epilepsy foci early. And we can see a process of what I would think of almost as kindling. And initially, for those who read EEG, and I'm assuming that is a majority of people listening today, you can see a focal spike here in the frontal central region on the right, and a 3-month-old child. And a few months later, at 14 months, you can see that this spike is now broad and hard to localize. And by 21 months, the entire right hemisphere is taken up by spikes. So there is a progression from focal spikes to regional spikes to hemispheric spikes, and eventually a pivot point to a global epileptic or diffuse epileptic encephalopathy. And we do not understand that process in full, and we don't have the medicines to stop it. But we are starting to see more and more that epilepsy surgery is a much more effective tool. And 40 infants enrolled in that big 160-person cohort that I spoke about earlier had more intensive EEG monitoring early in their phase. So we enrolled these patients at the neonatal age as babies, and we followed them for several years with repeat EEGs. And it turned out that when your EEG, just surveillance EEG, these children do not have epilepsy yet, converts from normal to abnormal, within about 3 months, you will have your first seizure. And the positive predictive value from the conversion or the emergence of the first spikes on the EEG, I'm not talking about seizures, had a positive predictive value in this subgroup of nearly 80%. And so we know when epilepsy, clinical epilepsy, is about to start. But the process itself starts much earlier. So what I've shown you so far in a nutshell is that when the EEG converts from being clean, here symbolized by the blank brain, to a focus, a first spike, here symbolized by the small dot, you know that epilepsy is about to follow. And then over time, if you don't do anything, this focus will grow, first expand locally, and then eventually expand regionally. And you can see this process beautifully in this patient that is followed here longitudinally. Another example, here is a 1-week-old with a normal EEG. You have to take my word for it. So a normal, clean brain. The story actually starts 3.5 months before birth, where you can see the tubers in the patient's brain. So we had the diagnosis beforehand. And at 2 months, the EEG is still normal. At 3.5 months, still normal. Here's some sleep spindles. And 5.5 months, still normal. And by 7 months, there is the emergence of a spike. And this is in fact a little polyphasic spike. And the patient is randomized to either placebo or treatment with vigabatrin. And that is part of a trial that I'm not going to talk much about today, but we were trying to see if we could preemptively treat epilepsy before it starts. And at 9 months, this spike continues to grow and recruit cortex or neighboring sites. And by 10 months, this patient develops a very subtle epileptic spasm, which is basically a seizure. And I'll skip the video just for time's sake. And by 11 months, this patient is now treated. This spike population is reduced in size because of exposure to medicine, suggesting that spikes are not only a biomarker of epilepsy, but they also track longitudinally with the degree of clinical control that you have. Unfortunately, by 15 months, these spikes started to ramp back up. And you can see them here. They're very broad in the right posterior quadrant. And by 21 months, the lid came off, and this patient has a diffuse epileptic encephalopathy. And if you see EEGs like this, you have no idea where everything started. The patient had a dramatic response to steroids, which is now the EEG is clean. And this is the patient's brain. So not easy to figure out which of these multiple lesions, here are all these white fluffy cortical or juxtacortical lesions, is guilty of causing these seizures, or maybe it's many of them. And this is the problem with these epileptic encephalopathies and how non-specific the EEG over time has become. Like when you think about West syndrome, spasms, and eventually development of LGS actually has a lot of overlap. Like the spasms, both clinically and EEG-wise, look a little bit like the tonic seizure that you see later on. And in the background in the EEG of ESES, markedly activated sleep spikes, look a lot like the slow spike and wave as seen in Lennox-Gastaut. And here's an example from two completely different patients. One is a 3-month-old, the other one is a 3-year-old. One is a spasm on the left side of the page, and the other is a tonic seizure on the right side of this slide. And they look alike. It's almost as if there is a kind of a convergence to a mean seizure type. And that is why we're thinking, like, if people have the exact same symptoms, but their lesions are differently distributed, or you can have spasms from a stroke or from a genetic problem or from traumatic brain injury, then how come these patients end up with the same EEGs and with the same clinical seizures? And actually, treatment sometimes is also broader, because vigabatrin was always thought to be only treating spasms, in particular in TSC, but it works remarkably well for tonic seizures. So I tell parents that tonic seizures are cousins of vigabatrin. All of this to say, and here's an example of slow spike and wave in an 18-year-old and an ESES pattern in a 9-year-old with completely different etiologies. So the EEG and the brain networks can only respond in so many ways. And that is a bit of the theme today, that once the brain networks are affected, you cannot really localize the original sources anymore. So what I've shown you so far is that EEG spikes predict focal seizures and that there's expansion, but how we go from focal seizures to global abnormal connectivity resulting in generalized seizure like spasms and tonic seizures is not known. And EEG is probably not going to give us the way, so we need MRI for that, and we probably will need to merge these two modalities, which is what we do with EEG source localization. So this ESES pattern that I spoke about earlier is associated with early thalamic injuries, for example, in perinatal stroke, as shown here. And it predisposes to ESES. So if the thalamus no longer can perform its cortical control, then you have a huge chance that these cortical thalamic oscillations are out of whack, and any type of seizure focus will then result in marked sleep activation like we saw. And likewise, spasms occur in those who have injuries to the basal ganglia, including the thalamus, or those with brainstem involvement, which was also shown in neonates with perinatal stroke. So deep gray and brainstem injury were those that were predisposed to spasms. So we asked the question, how is it possible that patients present with exactly the same symptoms, even though the lesion distribution that they have in their brain is vastly different? And that is what voxel-wise lesion symptom mapping and lesion network mapping do. And I'll tell you about both of these techniques. But we had 123 children that we recruited from this large group of patients with TSC, and with good imaging and good EEG data. Of the 123, 74 of them, actually a majority, developed infantile spasms, that generalized seizure type that we saw earlier, and others did not. And we localized their lesions on the brain and then put them into a common atlas space. So basically we asked what would the lesions be distributed like if we all put these lesions in a common single shared brain space. And here you can see the different lobes, and here's just one slice in the axial plane from one particular patient. Then if you add up all the subjects and make a heat map of the three-dimensional tuber distribution, you can see that it seems to be fairly stochastic. And the voxels, or the areas that are most affected by tubers, do not really add up much above 23. So fairly evenly distributed among the brain, although you could wonder if the motor strip is somehow spared. And when we do a visual comparison of those with infantile spasms and compare them to those who don't have infantile spasms, to the naked eye, these maps don't look very different. But we can actually quantify that, and we try to use a Bayesian adaptation of a generalized linear mixed model that tried to show, like, can we predict based on location who is at risk for tubers? And here the darker spots have more tubers on average in the 74 cases. And we were unable to predict infantile spasms on the basis of their location. But if you map the symptoms onto a network, then you can actually ask this question in a different way. So I'm going to go skip that previous slide and try and explain it directly in our own data. So if you look at the tubers of patient 1, patient 2, and patients all the way down to patient 74, and rather than looking at the locations and making a heat map of the distribution, what we did here, you can actually also ask the question, what networks would potentially be affected if this lesion were to occur in an otherwise intact network? So if you project for each patient, each lesion onto a normative connectome, so we don't do fMRI on these patients themselves, we use the average fMRI connectivity of 1,000 other children, and say, okay, if I have a lesion right here, what areas would be affected in an otherwise intact brain? And then you get, based on all these lesions, this distribution map of all these areas that are correlated or anti-correlated with the lesions. You do the same thing for patient number 2, same thing for all the other patients, all the way up to number 74. And then rather than putting the structural lesion distribution on top of each other to see if there are common denominators, we now put the functional connectivity maps on top of each other and threshold it. And then it turns out that 71 out of 74 patients had a tuber distribution pattern where tubers were connected to the internal globus pallidus and the vermis of the cerebellum. In other words, it's not where the tubers are, but what they are connected to, which gives you answers. So what these patients had in common was that in all of them, at least some tubers were functionally connected based on that normative connectome to this GPI, the globus pallidus internus. And we then turned that around and said, okay, which voxel in patients with IS are functionally more connected to tubers as compared to, as contrasted by those patients that did not develop infantile spasms. And we basically, if you see this as the sensitivity question, the answer is 71 out of 74. Then this would be the specificity question because we're comparing it to those who did not develop any spasms. And you can see here that the areas with tubers that were functionally more connected to tubers in case with spasms overlapped with those sensitive areas that we described. So these little areas here in the middle are both sensitive and specific to tubers, to infantile spasms. And then you can do the math on it. And why is this interesting? It's because this network was at the same time being described by collaborators from the Brigham and Women's who looked at post-stroke epilepsy. And Fred, here on the right upper corner, compared 625 patients who did not develop epilepsy after stroke to 76 patients who did develop epilepsy after stroke. And he found that their common denominator, just the same technique that we applied before, when placed in a normative connectome and then thresholded to see what the common denominators were, that the majority of these patients had their stroke lesions connect to the internal globus pallidus and the vermis of the cerebellum, and then also the substantia nigra and so on. So our network for spasms overlapped with an adult stroke cohort. And you can, that way you can build an epilepsy risk map, but that's kind of out of context right now. And this finding of the dentate nuclei in the vermis of the cerebellum, the supraremedial cerebellum, and two parts of the pons, the substantia nigra and the internal globus pallidus, could be reproduced in almost every population that we studied: trauma, patients with traumatic brain injury, tumors, tuber lesions. In other words, there is a risk map for lesions in the brain that you can say, well, if whatever lesion you have, whether it's a bleed or a brain tumor or a tuber, if these lesions are connected to any of these hotspots, then you have an increased risk for developing epilepsy. And the globus pallidus had been of interest in the past. In order to stay on time for the talk, I'm going to skip this. But basically, historically, people did pallidotomies. They would lesion the pallidum or the pallidum and the amygdala together to reduce this, the seizure frequency. And this is data now back from like over 70 years ago. So the globus pallidus was of interest already, in particular effective for salam convulsions, which is an old name for spasms. And there's some renewed interest in 2021, where a group of Japan reported that an intervention that's also tailored towards the globus pallidus, the internal globus pallidus. Here in red and blue are the projections of the internal globus pallidus onto the thalamus. And when they would lesion these fiber tracts right under the thalamus to stop these projections, and they did this for a movement disorder and for a form of dystonia, the patient's comorbid epilepsy also stopped or improved dramatically. So it was just a case series, but it was very interesting because it was almost that they stumbled upon this effect on epilepsy. And they said, well, this is really interesting, and we should consider the globus pallidus as a potential target again. I'm going to skip this for the sake of time. And I'm going to go back to TSC. So in epilepsy surgery, so we were wondering if these lesions project onto the globus pallidus, can we use that to identify a tuber lesion that is causing seizures and differentiate it from other tuber lesions that are not causing seizures? And for that, we segmented, we marked the tubers in all these patients that had undergone epilepsy surgery. And the resected tuber here highlighted in red, we refer to as the targeted tuber, and when the patient would become seizure-free, that would also be the so-called epileptogenic tubers, and these other tubers then become non-epileptogenic because the patient is seizure-free while these lesions are left in place. And when we compared the connectivity of tubers that caused epilepsy to tubers that did not cause epilepsy, we found that the tubers that cause epilepsy appear to be outside of this lesional network. And the negative connectivity with those same nodes that we described earlier, the vermis of the cerebellum and the internal globus pallidus, is mainly the lesional tubers, but that are not electrically active that project onto this region. Now, I may have lost you, so I'm going to go back to summarizing, and then we'll move on to EEG. So going back to like the network effects of EEG abnormalities and how to identify these targets a bit more accurately, is we know that an injury to the basal ganglia predisposes to spasms. We also know that lesions that are functionally connected to the GPI predisposed to spasms. We saw that from the lesion network mapping work. And then more broadly from the adult stroke world, we saw that lesions that are functionally connected to all of those nodes from the network predisposed to epilepsy in general. Now, how can we merge EEG and MRI? That is where electrical source imaging comes in, and that's where I'll show you some of my older work if time permits, and then I'll try to wrap it up by explaining where the field is heading using these two key modalities, MRI and EEG. And so the old days of localizing spikes was just looking at the EEG, and there's a phase reversal over F4, C4, and that would be the end of it. Okay, well, maybe there is an average that tells you a bit more, or maybe even a Laplacian reference, and perhaps a voltage map if you want to get really fancy. But source imaging is a much more sophisticated way of bringing EEG and structural images like MRI into the same space. And I always compare it to popping popcorn kernels inside of a balloon, and the kernels leave an ink splatter behind on the rim of the balloon every time they hit a rim, and then the ink splatter pattern tells you where the origin of the popping kernel was. Or like Dexter was doing in his TV series, the splatter pattern on the wall of blood would be deduced to where the gun was fired. And so basically, Dexter was solving an inverse problem there. And for those of you who are familiar with electrical source imaging, this is an ill-posed problem, meaning that you can come up with a perfectly mathematically feasible solution that seems sensible, but it may be inaccurate, as illustrated here by this dinosaur that's reconstructed, but with insufficient information, and reconstructed poorly, but renders a perfectly feasible dinosaur. And it has to do with the fact that there are multiple solutions equally feasible. And one of the ways of reducing this ill-posedness, and that's the ESI work that I wanted to talk about, is that the number of possible dipoles vastly outnumbers the electrodes, and therefore you need either a lot more data, more electrodes, or you can reduce the number of candidates, for example, by introducing constraints into the model. And that's what we did with tuberous sclerosis complex, because as I was explaining earlier, often the epilepsy can be reduced to one or two tuber lesions out of many more. And so when we realized that, we thought, okay, well, what happens if we tell the computer that only the tubers can, that the solution basically needs to be constrained to tubers. And so we built a forward head model, like any other forward head model, and we used a finite difference method to create a lead field matrix. But then when we were reconstructing, we gave every tuber its own unique chance to approximate the surface signal with EEG. And basically, we forced the computer to think in boxes. So here's an example of a patient with a frontotemporal source on scalp EEG, and this is low density EEG. And you can see that if you introduce typical cortical constraints, that the distribution gets, the solution gets smeared out over somewhere in between the frontal lobe and the temporal lobe. And eventually this patient underwent a frontal resection, not a temporal lobe resection, as you can see by this cavity that we projected onto this brain. But when we used our lesion constrained electrical source imaging, the lesions are color coded by their ability to explain the scalp EEG. And this lesion was clearly the hottest and fell smack in the cavity, the future surgical cavity of this patient, and the patient was rendered seizure free. Here's another example. The S-Loretta solution basically applied prior to this surgical cavity, so that is a bit confusing, I admit, showed a solution that was maximal somewhere in the posterior rim of where the tuber sat, because the tuber sat here. But when we applied that lesion constrained ESI, the hottest tuber was clearly this guy, which fell in the resection cavity and the patient was seizure free. So on both occasions, the source solutions with S. loretta were bordering the targeted tuber areas, but were ambiguous. And in lesion constrained ESI, you can see that this source space gets reduced further. And it's not fail-safe and not a good standalone method, but it is a nice addition to other forms of source localization. And then with high density EEG, you can obviously get much more data for fitting, whether it's MEG or high density EEG. And here demonstrated by a 128 electrode headnet from what was then called EGI. And I think it's EGI maxed in now. And here the forward model of the patient's own brain. And when we applied lesion-constrained ESI with high-density EEG, the solutions turned out to be really highly accurate. So here is a patient with tuberous sclerosis complex who has spikes in C4. I'm sorry that the electrode labels fell off. And he has, you can see the low electrode count. This was done in Curie 7. And you have a broad field and a poor slope. So it looks like some kind of random radial source going into the brain here. But then when we did high density EEG, you can see that the field is much more narrow. It has much more depth with the gradient here. And the voltage topography map is much more sophisticated, if you will, or detailed. And in this one, you can see a focal maximum of the positive end of the dipole in front. So you get a dipole that is somewhat facing backward. And I'll just zoom in a little bit. So this dipole is already quite nicely implicating this tuber complex in the vicinity. But with lesion constraints imaging, this we could nail this down even more. So the S. loretta solution indicated roughly where the tuber of the culprit tuber could be, but it's a bit posterior of it, the top right image here in the sagittal plane. But when restricting the solution to each of the tubers and then seeing which tuber performed best, you can see that these tubers were highlighted as the ideal candidate. This also has to do with the fact that the cortex overlying the tubers is abnormal and often does not get segmented properly, so it may not even be included in your constrained space. And this is the patient after surgery, and he's doing phenomenal. I've been following him for at least a decade now, and he's doing fantastic. Then a quick word on another opportunity to smoothen the way of collecting multiple interictal spikes. Rather than averaging and then trying to get to extract key components using ICA or PCA, we came up with a more sophisticated method. And I'm typically very proud of fully understanding the math behind it, but in this one, it's clearly above my head. Here is the original EEG data. And I'm reading from a cheat sheet here. The original data is divided into short time segments. We use an ARLTI dynamical system to estimate state space trajectories for each of these segments. So basically, recurrence patterns of these little mini segments. And then we approximate that electrode observation model to approximate the original data. So you can see that the ARLTI approximation resembles the original data. And then we translate that into the source observation matrix. So what this looks like is that here you can see the propagation of a spike with PCA and ICA on the left and with our new algorithm on the right. And you can see the slow flare up and distribution and recruitment of the adjacent cortex. And here's the same thing, but you can see the seizure propagation occur on the right side in a much more natural way. And this is a similar video that I will skip. All right, so in the few minutes that I hope I have left, when you summarize EEG and fMRI and MRI, it seems that there is a gating mechanism for spasms, and that if you have focal seizures, that the basal ganglia here indicated in red are somehow preventing focal seizures to trigger spasms. But if that system is overwhelmed by a larger focus, you can develop spasms after all. Or if you have an injury to the basal ganglia down here, then you may not be able to protect against spasms. If you have multiple regions projecting onto this same area, then you can also get spasms. And if there are areas that don't project onto the basal ganglia, then they don't contribute. So it is a combination of both a push and a pull where the entire network gets overrun when this gating mechanism fails, and we know that this is GABAergic. Then briefly to the intervention. I will not talk about medical interventions in TSC. It's not the right audience. But again, we're focused on whether or not epilepsy contributes to poor development, because only then can we reduce seizures and improve development. And it is absolutely worth pursuing epilepsy surgery in TSC. It is a very rewarding type of endeavor. And if you do it exactly right, you can actually find tubers that drive spasms. And we have just seen that spasms are generalized seizures, but sometimes you can actually find the tuber focus that drives these generalized seizures, kind of confirming the network theory. We can also confirm it the other way around, that with resection of the focus, that the focal seizures can resolve. I'll skip this stuff. I wanted to show you very briefly the developmental benefits on epilepsy surgery. Here's the same Mullen early learning scores that we saw in this group before. 20 out of the 160 patients underwent surgery before age 2 and therefore had follow-up by age 3 that was at least a year, and also had neuropsych testing. And their Mullen scores of early learning, when you track them at 3, 6, 9, 12, 24, and 36 months. For those without epilepsy in purple, they hover around 100, so normal. Those with epilepsy but with control, their developmental gap increases over time. Those with refractory epilepsy have a developmental gap compared to their peers that widens more fast. But with epilepsy surgery here in green, this trajectory then bends back towards the normalized scores. And the same goes for these two language scores. You can see this green trajectory crossing the red line, which are the same or similar patients with refractory epilepsy that do not undergo surgery. And we demonstrated after that that there were, demonstrable benefits of doing it earlier, that every month delayed would result in greater delays. And there are likely behavioral benefits as well. Even repeat surgeries is okay. So we're going from like one big surgery going for broke to now multiple repeated small surgeries. And then finally, my last slide, we are slowly but surely working towards more network-informed treatments. And here, for example, are adults that had their anterior thalamic nucleus implanted. In blue, the anatomical target on an average brain. And then many patients, I forgot how many, but let's say 40 or 30, combined, and all of their electrodes are here projected to see where they end. And you can see some that overshoot, and some are in front of the ANT, some are lateral of the ANT. And when you model their activation volumes here in the VAT, in the red little globe, it's the volume of activated tissue. So based on the parameter settings of the stimulation in DBS, you can model how much tissue sees any of that current. And then you can determine how much of the ANT is actually stimulated, right? You can look at the overlap between the activated tissue from the electrodes and the ANT. And it turns out that the overlap with the previously described network, the globus pallidus, the internal globus pallidus, and the vermis of the cerebellum, the overlap with that network predicts the response to DBS better than the physical overlap with the ANT. In other words, it's the network perhaps that gets tickled that drives this seizure response. And so the optimal area to stimulate would actually be slightly anterior and inferior of the ANT node, which is very interesting. So here is where we're combining the knowledge about epilepsy networks, e.g. stimulation parameters, and to see if we can optimize targeting the network nodes rather than the focal seizures. So I'm sorry for the breakneck speed. I thought I had a bit more time, and I hope that I didn't lose you. But again, seizures have local, regional, and eventually diffuse network effects, and not all of that is just from synchrony, but it is from these seizures basically tapping into healthy existing networks that you and I also have, resulting in a network disorder. And the interventions more and more are not only focused at the focal generator, if we can find out where it is, but also at key nodes of the network. And practically speaking, earlier is better, because then you can actually not only prevent this epileptic encephalopathy, but you can also salvage neurodevelopment. So I'll take, I'm happy to take some questions.
All right. Thank you very much, Dr. Peters. That was excellent talk. Very much appreciate it. We do have some questions for you. Let's see here. We have, how do you view MRI mapping post-trauma lesions affecting predictive medicine and additional testing?
If I understand the question correctly, so the method that I showed you is based on existing networks. So if you have a patient with traumatic brain injury, the first order of business is to delineate on that patient's own brain where the injury is. And let's say that there is a small right frontal injury, just for the purposes of illustration. Then you warp that patient's affected brain onto a normal brain. And then you apply that warp, like, the stretching, the skewing, and the altering that you need to do onto that normal, onto the lesion, onto the injury as well. And so then you get basically your traumatic brain injury lesion, what it would look like if it were to be, were to occur in a standardized average brain. And from there, you can project the average, you can project that lesion not just on the average brain, but also on the average connectome, and you can hypothesize which connections would be affected. I hope that answers your question.
Thank you very much. Let's see, we have another here. Thanks for the very interesting and excellent talk. Are there any suggestions or pitfalls when localizing broad spikes as compared to sharp spikes?
Yes, I love that question, because I sometimes get frustrated when we send patients to the MEG, and sometimes that is the difference between a clinician and an engineer, and or somebody who's like a pure physiologist. The MEG results, if you send somebody with a generalized spike to the MEG, sometimes they return with bifocal spike populations as mapped by their dipoles, with two little dipoles sitting somewhere deep in the white matter of the frontal lobes, projecting forward. And while that may be an accurate summary of the electrical activity at its peak, it does not really localize its origins. What it does is it gives a summary measure of where the maximum electrical activity is, but it doesn't say anything about the process or where you are to stop it. And whether or not these spikes are generated by an interplay of the abnormal thalamus and the cortex, for example, is unknown. And these are also not source localizations that can help you go after the source, right? Either you have, with a distributed source solution, you would have a super broad bifrontal or almost whole head source, or you can have a deeper source sitting somewhere in the white matter, but that's not really the source. That's just the electrical, point of maximum activity. And so mapping generalized or diffuse spikes can be very tricky. And I don't think we have a good answer for it, but I'm happy to hear from others.
There's actually a good follow-up to that here. Are there any ways to estimate the size of the active area from EEG?
Yes, and in regular EEG, when you interpret it clinically, you can look at the size and the field of a spike, like I showed you earlier when we went from focal spikes to regional spikes to hemispheric spikes. And with source localization, you can also chart the amount of cortical volume that is engaged with generating that abnormal electrical signature on the EEG. So you can use ESI and source imaging to estimate the swath of cortex that's generating this spike. So yes, there are tools to do that. With the naked eye in a clinical EEG, it's a little trickier, but sometimes we do that for clinical purposes too.
Great, thank you. Let's see here. Since the TSC has a different tissue density and therefore different conductivity, do you think that will affect the accuracy of building the head model?
Yes and no. Yes, because your question is exactly right. It has different densities, and we probably are not taking into account the exact biophysical propagation properties of this tissue into account. No, because often good enough, it works in clinical contexts. So for the research scientists, sometimes people come up with sub-millimeter accuracy with extremely high density EEGs and 256 sensors and so on, only for the solution to move a millimeter or three. But for the clinician, it's often good enough to say, like, well, I have plenty of evidence that this is the culprit tuber, and whether we're off by a few millimeter or not doesn't really matter. So yes, in theory, correct. Maybe for the engineers, for the clinicians, often near perfect is good enough.
Thank you. Let's see, we have one that I think you kind of answered in your talk, but it's worth discussing, and I'm actually going to add to this question as well. The question is, do you believe that the current 1010/1020 electrode placement are sufficient for reliable localization? It's part one. Part two, my part is, what do you think are the required modalities? And do you think, what are the optimal modalities? Like, do you think adding a metabolic modality like PET would be informative in this process?
Yeah. So I'll answer the second part first, because that's the easier one. I think that most hospitals will use PET, and I'm not talking about TSC specifically, but it depends really on if their patient is lesional or not. With regards to the EEG, we have insufficient coverage to see the full extent of the electrical field when you use 1020 coverage or even 1010 coverage. So if you have a handful of electrodes, most of these electrodes are still covering so-called northern hemisphere, right? It starts above the eyebrow and runs as a head circumference measure tool around the head. And we don't see the counter side of the dipoles. So if there's a source sitting right under the surface in your forehead, and the back end of that dipole is projecting onto the other side of the skull, the sources will actually end up, not the sources, sorry, the opposite end of the field, so in this case the positive field, will be sitting somewhere in your neck, and there's no electrodes measuring it. So with this limited electrode coverage, you will not only have limited spatial resolution in those areas that it matters, but you will actually miss a whole part of the equation. And so I think it is important that in those patients who tolerate it, that you also cover lower portions of the head, like we're talking P9, I forgot what they're called, not 7, F9, I believe, and so on. So lower electrodes, and that's why the EGI nets had coverage all the way into the face, so that you can actually see the full extent of the abnormal electrical fields.
Excellent. Jurriaan, really appreciate having you today. I'm sure we are going to receive more questions and inquiries regarding your talk. We will be sure to forward those to you. But we really appreciate you taking the time to speak with us and present the amazing work that you're doing. So thank you very much.
Great, I enjoyed it. And again, sorry for the kind of breakneck speed. I thought I had a bit more time.
No, we're all good. I have a feeling that we are going to continue this conversation in the not so distant future. We're looking forward to
Excellent.
it.
All right, I love working with you guys, and see you soon.
Thank you very much. We'd like to also thank the audience for attending. Please keep an eye out for our newsletter and upcoming events. And we will see you all soon. Thank you.
Thank you. Bye-bye.